So, we will start from ECG electrophysiology some words, and then we will talk about ECG criteria of hypertrophy of different chambers of the heart and ischemic heart disease. So I think you know about action potential, the phases of action potential, but few words to recall your knowledge. So the action potential consists of 4 phases. The first phase, the phase 4, resting phase, only potassium channels are open during the resting phase, and efflux, outward flow of potassium, establishes a negative resting membrane potential. Then follows phase 0, depolarization. Upon stimulation, rapid depolarization occurs via influx, inward flow of sodium, and the cell becomes positively charged. The next phase 1, early repolarization. During this phase, another type of potassium channels open, and a brief efflux of potassium repolarizes the cell slightly. Phase 2, almost simultaneously with the opening of potassium channels. In phase 1, persistent calcium channels open, whereby calcium flows into the cell. The efflux of calcium is steady and gives rise to the plateau phase, whose long duration explains why the vast majority of the ventricular myocardium contracts simultaneously. And the last phase, phase 3, repolarization. Calcium channels close and potassium channels open again, and the efflux of potassium repolarizes the cells. So as seen in the figure 2, the relative refractory period coincides with the T-wave apex. This phase has traditionally been described as a vulnerable phase during the cardiac cycle because electrical stimulation during this phase may evoke another action potential, which can lead to potentially life-threatening ventricular arrhythmias, for example, ventricular fibrillation. This occurs occasionally in clinical practice. The stimulus is typically a premature ventricular beat, for example, an ectopic beat from within the ventricles, or inappropriate stimulation from an antifacial pacemaker. When such a ventricular depolarization is superimposed on the T, it is said an R on T phenomenon has occurred. However, it should be noted that R on T phenomena are very common, and the risk of ventricular fibrillation is negligible unless there is electrical instability in ventricles, such as during acute myocardial infarction. This figure shows the classical ECG waveforms. The first deflection, henceforth called wave, is the P wave, which represents activation or depolarization of the atria. The repolarization of the atria is usually not visible because it occurs simultaneously as the activation or depolarization of the ventricles, which generates subsequently larger electrical potentials and therefore dominates that moment in the cardiac cycle. Ventricle depolarization is visible as QRS complex. The QRS complex consists of 3 waves, Q, R, and S. Differences in the direction of these waves are due to changes in the direction of the electrical impulse during ventricular depolarization. The T wave represents a repolarization or relaxation of the ventricles. Note the straight line between P wave and QRS complex, so-called PQ or PR segment. This line is referred to as PQ segment and represents the impulse delay in the atrioventricular node. So this is the list of basic leads of ACG. Standard leads, there are 3 standard leads, 3 augmented leads, and 6 chest leads. Standard leads: the first, right arm, left arm; the second, right arm, left foot; the third, left foot, left arm. So this figure demonstrates the organization of the limb leads. Note that the electrode on the right leg, this black electrode, is not included in any lead, but serves as a ground wire. Leads, the first, the second, and the third standard leads are Einthoven's original leads, and they can be presented with Einthoven triangle. Lower panel. Leads AVR, AVL, and AVF were constructed by Goldberger, and their reference point is the average of 2 electrodes. Optionally, the ACG model can also be used to determine the unipolar leads. The unipolar leads measure the potential of 3 limbs relative to the potential at infinity, to 0 potential. With this setup, they can be measured directly according to their definition, for example, by simply measuring to the voltage of the limbs relative to the 0 potential on the direct current power unit. In practice, the 0 potential is approximated by the mean potential of all the limb electrodes, so-called Wilson central terminal, or by the mean potential of 2 opposing limbs, Goldberger augmented unipolar leads. In the latter case, the unipolar leads can be calculated from the bipolar leads, standard leads, the first, the second, and the third, with the equations, which are presented on this slide. So this is the position of chest leads, 6 chest leads. They are positioned along lines and intercostal spaces. So, and the limb leads, 6 limb leads, have the exploring electrode and the reference point placed in the frontal plane. These leads are therefore excellent for detecting vectors traveling in the frontal plane, picture A, and the chest or precordial leads have the exploring electrodes located anteriorly on the chest wall and the reference point located inside the chest. So the chest leads are excellent for detecting vectors traveling in the horizontal plane. This figure shows that the 12-lead ACG records information on electrical activity of the left ventricle and not so much of the right ventricle. As seen in this figure, the left ventricle has the shape of bullet, and the left ventricle is traditionally divided into 4 walls. In the figure shows which lead the best observe electrical activity of each wall. So you must remember this table, next table, that inferior wall of left ventricle is detected in the second, third standard lead and AVF. Lateral wall, the first standard lead, AVL, V5, V6. Anterior wall of left ventricle, V3 and V4 chest leads, and septal intraventricular septal, V1, V2 chest leads. It is fundamental to know the genesis of the waveforms of ACG, and this requires knowledge of the electrical vectors that exist during the cardiac cycle. So, electrical vector is a physical quantity which has both magnitude and direction in space. Movement of electrically charged particles which occur during spread of the cardiac action potential generates an electric vector. The depolarization propagates through the myocardium similar to the spread of a wave front in the water. At any given instant in time, there are numerous small depolarizing waves fronts that propagate through the myocardium, and the average of all individual wave fronts at any given instant in time represents the main electrical vector. Thus, the electrical vector is the average direction of the impulse. Hence, the ACG waveforms displayed in the beginning of our lecture actually represent the electrical vectors of the cardiac cycle. So in order to understand how an electrical vector generates a wave on the ACG curve, it is crucial to understand how ACG leads function. Note that the ACG leads were discussed, so the ACG machine device uses two electrodes to calculate ACG curve. This is done by comparing the electrical potentials detected by each of the electrodes. One electrode is defined as positive exploring electrode, and another is negative reference electrode. The electrocardiograph compares the electrical potentials detected by the exploring electrode and the reference electrode, and the machine is constructed such that a vector heading towards the exploring electrode records as a positive deflection or positive wave on ACG, and vector heading away from exploring electrode will record as negative wave. So this picture illustrates that we've got four vectors of electrical vectors. The first electrical vector is the depolarization of atrium, begins in sine-atrial node. The first right atrium is depolarized, then left atrium, and at ACG we've got P wave. The second vector, the intraventricular septum, this vector, the ventricular septum receives Purkinje fibers from the left bundle branch, and therefore depolarization proceeds from its left side towards its right side, and the vector is directed forward and to the right. The ventricular septum is relatively small. That is why V1 displays a small positive air wave, and V5 and V6 displays a small negative Q waves, like in this example. Thus, it is the same electrical vector that results in an air wave in V1 and small Q wave in V5. The third vector, the ventricular free wall. The vectors resulting from activation of the ventricle free walls are directed to the left and downwards. So the vector resulting from activation of the right ventricle does not come to expression because it is drowned by the many times larger vector generated by the left ventricle. Thus, the vector during activation of the ventricle free walls is actually the vector generated by the left ventricle. Activation of the ventricle free wall proceeds from the endocardium to the epicardium. This is because the Purkinje fibers run through the endocardium, where they deliver the action potential to contractile cells. The subsequent spread of the action potential occurs from one contractile cell to another, starting in the endocardium and heading towards the epicardium. So, and as evident from this picture, the vector of the ventricular free wall is directed to the left and downwards, and lead V5 detects a very large vector heading towards it and therefore displays a large air wave in V5 and V6, and lead V1 records the opposite and therefore displays a large negative wave, which is called S wave. The last vector, the fourth vector, basal parts of ventricles. The final vector stems from the activation of the basal parts of the ventricles. The vector is directed backward and upwards. It heads away from V5, which records a negative wave, S wave. Lead V1 does not detect this vector. So, and at the end we have a mean electrical axis, which is directed to the left and down, mean electrical axis. Although often ignored, assessment of the electrical axis is an integral part of ACG interpretation. The electrical axis reflects the average direction of ventricular depolarization during ventricular contraction. The direction of the depolarization, and thus the electrical axis, is generally alongside the heart's longitudinal axis to the left and downwards. So, and the position of electrical axis of heart changes with changes of the position of the heart in the chest. The relation between the electric axis and the magnitude of the Equerres complexes in standard leads is described by the so-called Eindhoven triangle. The electrical axis of the heart is determined by the shape of ventricular complexes in standard leads. So normal electrical axis when the most prominent air in the second standard lead. Horizontal position of electric axis, or also called levogram or left axis deviation, is determined when the most prominent air wave in the first standard lead. And vertical electrical axis or dextrogram or right axis deviation is determined when the most prominent air is in the third standard lead. So for calculating of electric axis, we may use this frontal plane axes of the three bipolar and three unipolar leads. So we must how to calculate by plotting the mean electric axis of ventricles from two electrocardiographic leads. We use the first and the third standard lead. And this figure shows the coordinate system where this segment, rose segment, displays the range of normal heart axis from -30 to +90, this is normal range of hot axis. This is right axis deviation and left axis deviation. Another picture which illustrates the same, maybe also useful for you. Causes of right axis deviation. It is normal for newborns, and the most spread causes of right axis deviation are right ventricle hypertrophy, acute copulmonale in case of pulmonary embolism, chronic copulmonale, which is developed in case of COPD, pulmonary hypertension, and so on, and right bundle branch block. Causes of left axis deviation. The most common are left bundle branch block and left ventricle hypertrophy, and sometimes inferior myocardial infarction. Some words about conduction system. I think you know about conduction system. So the sinoatrial node is the primary pacemaker of the heart. However, there are additional structures that possess atomicity and thus the ability to serve as the heart's pacemakers. These structures are as follows: parts of the atrial myocardium, myocardium surrounding the atrioventricular node, and his Purkinje network. So this figure demonstrates the pacemaker structure. So overview the electrical impulse during a cardiac cycle and the pacemaker hierarchy. All pacemaker structures are capable of spontaneous depolarization or atomicity and can therefore serve as the heart's pacemaker. The rate of spontaneous depolarization is highest in the sinoatrial node. That is why it is the primary pacemaker. And now we will talk about waves and segments of ECG. So we have talked about P wave, PQ interval, QRS complex, ST segment, and T wave. For the first P wave reflects the depolarization of atriums, and we've got two atriums, right and left. That is why P wave consists of two parts: depolarization of right atrium and depolarization of left atrium. Sinoatrial node is in right atrium. That is why P wave starts from depolarization of right atrium. You must remember that the P wave is always positive in the second standard lead if the rhythm is sinus. P wave may have two humps due to depolarization of right atrium and left atrium. And in the V1, it may be biphasic due to negative deflection caused by depolarization of left atrium. So this is normal P wave. P wave checklist. So pay attention on this checklist. This is a description of normal P wave, and when we will talk about hypertrophy of right and left atrium, in order to find this hypertrophy you must know the description of normal P wave, this checklist, in order to find the abnormalities of P wave. Next, PR interval or PR segment. The PR interval starts at the one set of P wave and ends at the one set of QRS complex. It reflects the time interval from the start of atrial depolarization to the start of ventricle depolarization. The PR interval is assessed in order to determine whether impulse conduction from the atria to the ventricles is normal in terms of speed. The PR interval mustn't be too long nor too short. A normal PR interval ranges between 0.12 seconds to 0.22 seconds. The flat line between the end of the P wave and the onset of QRS complex is called the PR segment, and it reflects the slow impulse conduction through the atrioventricular node. The PR segment serves as the baseline, also referred to as reference line or iselectric line of the ACG curve. The amplitude of any deflections and waves are measured by using the PR segment as the baseline. I emphasize this information because when we will talk about elevation and depression of ST segment, it is very important to know what does it mean baseline or iselectric line. So PR segment serves as the baseline. This figure shows the conduction through AV node. So conduction through AV node once again is reflected by PR or PQ interval from the beginning of P till beginning Q or R wave. It may be prolonged when we have block, AV block, or it may have an additional wave, delta, so-called delta wave, in case of existence of an accessory path waves between atria and ventricles. PR interval checklist. So once again, normal PR interval from 0.12 to 0.22 seconds. Prolonged PR interval is considered to reflect the AV block, the first degree of AV block. If PR interval is less than 0.12, it indicates the excitation, so the presence of accessory pathways. QRS complex. A complete QRS complex consists of Q, R, and S wave. However, all three waves may not be visible, and there is always variation between the leads. Some leads may display all waves, whereas others might only display one of the waves. So examples of naming of the QRS complexes. This is examples. So when the first and only wave is positive, it is R wave, RS, the prominent R and small s, negative. Initially small r and deep S, so we will call it small r and big S. This is full complex, complete QRS complex, which includes small q negative, r positive, and s negative. QR complex, when we have pathological very pronounced Q wave, negative wave, and pronounced R wave. QS, when we have only one negative complex the wave, it is called QS. Large negative pathological Q and very small positive R, and M shape of R of QRS complex is called RS R wave. Some another examples. Of QRS complex. And airwave checklist. So it is important to assess the amplitude of airwaves in order to find the hypertrophy of ventricles, right or left ventricle. So this is the checklist of airwave in different leads. You must remember this checklist in order to find the abnormalities, the criteria of hypertrophies. The very important idea, the airwave progression. Airwave progression is assessed in the chest precordial leads. Normal airwave progression implies that the airwave gradually increases in amplitude from V1 to V5 and then diminishes in amplitude from V5 to V6. The S wave undergoes the opposite development. Abnormal airwave progression is a common finding which may be explained by any of the following conditions. For the first, myocardial infarction. Necrotic myocardium does not generate electrical potentials and therefore there is a loss of airwave amplitude in the ACG leads reflecting the necrotic area. Cardiomyopathy may cause either loss or gain of airwave amplitude depending on the type of cardiomyopathy. Amplitudes may be increased in hypertrophic cardiomyopathy, whereas they are typically diminished in late stages of dilated cardiomyopathy. Right and left ventricle hypertrophy also amplifies the airwave amplitude. Left ventricle hypertrophy causes increased airwave amplitudes in V4, V6 and deeper S waves in V1, V3. Right ventricle hypertrophy causes large airwaves in V1, V3 and small airwaves in V4 and V6. Pre-excitation, bundle branch block and chronic obstructive pulmonary disease may also affect airwave progression. So this picture illustrates normal airwave progression and abnormal airwave progression, airwave loss in case of myocardial infarction. Q wave. It is crucial to differentiate normal from pathological Q waves, particularly because pathological Q waves are rather firm evidence of previous myocardial infarction. However, there are numerous other causes of Q waves, both normal and pathological, and it is important to differentiate these. The amplitude, the depth, and the duration, the width of Q wave dictate whether it's abnormal or not. Pathological Q waves have a duration more than 0.03 seconds or amplitude more than 25% of the airwave amplitude in the lead, in the same lead. Pathological Q waves must exist in at least 2 anatomically contiguous leads. It is very important idea. For example, neighboring leads such as AVF and third lead, V4 and V5, in order to reflect an actual morphological abnormality. The existence of pathological Q waves in 2 contiguous leads is sufficient for a diagnosis of Q wave infarction. Normal variants of Q wave. Septal Q waves are small Q waves frequently seen in the lateral leads. V5, V6 are VL and the first standard lead. They are due to the normal depolarization of the ventricle septum. 2 small septal Q waves can actually be seen in V5, V6. An isolated and often large Q wave is occasionally seen in the third standard lead. The amplitude of this Q wave typically varies with ventilation, and it is therefore referred to a respiratory Q wave. So note that the Q wave must be isolated to the third lead without presence of Q wave in RVF lead. So this slide shows normal and pathological Q waves. Patient 1 has normal septal small Q wave in V6. The patient number 2 is a patient with STEMI 5 days earlier, so he has pathological Q waves in V4, V5 and V6. So its duration more than 0.03 seconds and its depth is more than 25% of air wave. And patient number, in this case, Q wave reflects necrosis of cardiomyocytes. And patient number 3, with a history of STEMI, he has loss of air wave in V1 and V2 and V3, and QS complexes in V1, V2 and V3 chest leads. ST segment depression and ST segment elevation. So ST segment corresponds to the plateau phase of the action potential. The ST segment extends from J point to the onset of T wave. Because of the long duration of the plateau phase, most contractile cells are in the phase at the same time, more or less. Moreover, the membrane potential is relatively unchanged during the plateau phase. These two factors are the reason why the ST segment is flat and easy electric, so it is recorded on the baseline normally. Displacement of the ST segment is of fundamental importance, particularly in acute myocardial ischemia, because myocardial ischemia affects a limited area and disturbs the cell's membrane potential. It engages an electrical potential difference in the myocardium, and the electrical potential difference exists between ischemic and normal myocardium, and it results in the displacement of the ST segment. The ST segment may be displaced upwards, elevation, and downwards, depression. The term ST segment deviation refers to elevation and depression of ST segment. The magnitude of ST segment deviation is measured as the height difference in millimeters between J point and PR segment. This J point and PR segment of baseline. Normal ST segment, the checkup of ST segment is flat and easy electric. The transition from ST segment to T wave is smooth and not abrupt. ST segment deviation, elevation and depression is measured as the height difference between J point and baseline once again. There are primary and secondary ST and T changes. Primary ST and T changes are caused by abnormal repolarization. This is seen in ischemia, electrolyte disorders, tachycardia, drug side effects, and some others. Secondary STT changes occur when abnormal depolarization causes abnormal repolarization. This is seen in the bundle branch block, left and right bundle branch block, ventricular hypertrophy, premature ventricular complexes, and pacemaker stimulated beats. ST segment depression. The reference point is, as usual, the PR segment. ST segment depression less than 0.5 millimeters is accepted in all leads and is considered to be normal. ST segment depression 0.5 millimeters or more is considered to be pathological. Some experts' consensus documents also note that any ST segment depression in V2, V3 should be considered abnormal. There are several types of ST segment depression. If we are talking about acute ischemia, the most typical are horizontal depression and down-sloping depression. And different types of horizontal and down-sloping depression. Secondary or repolarization abnormalities or secondary ST and T wave changes are presented on this slide. For example, the first is ST segment depression in case of left bundle branch block. The second is depression of ST segment in a left ventricle hypertrophy in the V6 lead and right ventricle hypertrophy in V1, V3 chest leads. This is right bundle branch block in V1, also depression of ST segment. ST segment elevation is measured also in the G point in the setting of chest discomfort or other symptoms suggestive of myocardial ischemia. ST segment elevation is an alarming finding as it indicates that the ischemia is extensive and the risk of malignant arrhythmias is high, and elevation of ST segment reflects the ischemic injury. There may be different types of ST segment elevation: convex, straight up sloping, straight horizontal, straight down sloping. This is the most typical for ischemia. And non-ischemic ST segment elevation is concave. This is another examples of ST segment elevation caused by ischemia, and a real example of ACG in patient with STEMI. And you see that there are ST segment elevation in the second standard lead AVF and third standard lead, and vice versa. In AVF, the first standard lead are depression of ST segment. It is called reciprocal ST segment depression or discordance. T wave. Some words about T wave. Assessment of T wave represents a difficult but fundamental part of ACG interpretation. The normal T wave in adults is positive in most precordial and limb leads. The T wave amplitude is highest in V2 and V3 chest leads. The amplitude diminishes with increasing age. The T wave is normally slightly asymmetric since its downslope second half is steeper than its upslope first half. Women have a more symmetrical T wave, a more distinct transition from ST segment to T wave and lower T wave amplitude. The T wave should be concordant with the QRS complex, meaning that a net positive QRS complex should be followed by a positive T wave and vice versa. Otherwise, there is discordance, means opposite directions of QRS and T, which might be due to pathology. A negative T wave is also called an inverted T wave. This is T wave checklist, the normal description of T wave. Normal variants of T wave. Large T waves. For example, hyperacute T wave can be seen in transmural ischemia. Biphasic T waves, which have positive part and negative part. And negative or inverted T waves, different types and different causes of negative T waves. Ischemia never causes isolated T wave inversions. It is a general misunderstanding that T wave inversions without simultaneous ST segment deviation indicate acute or ongoing myocardial ischemia. T wave inversions without simultaneous ST segment deviation are not ischemic. However, T wave inversions that are accompanied by ST segment deviation, either depression or elevation, is representative of ischemia, but in that scenario it is actually the ST segment deviation that signals that ischemia is ongoing. So we finished this part of our lecture. Now we will talk about hypertrophies and the sequence of ACG analyzing. For the first sequence of ACG analyzing, so when we've got an ACG record, we start from estimating of voltage of ACG with standard size of 1 millivolt, must be 10 millimeters. To that end, that amplitude of air waves is measured in standard leads. Normal amplitude is from 5 to 15 millimeters. If the amplitude of the highest air wave does not exceed 5 millimeters in standard leads, or the sum of amplitudes of these waves in all three leads is less than 15 millimeters, the ACG voltage is considered decreased, and it may be, for example, in case of myocarditis or myocardial infarction. The next, we must estimate the speed of the tape. There are two speeds of the tape recording of ACG, 50 millimeters per minute and 25 millimeters per minute. So if the speed of the tape is 50, it means that one small box, 1 millimeter, is equal to 0.02 seconds. If the speed is 25, it means that one box, 1 millimeter of the tape, is equal to 0.04 seconds. Then we must estimate the regularity and pacemaker of cardiac rhythm. Then we must calculate the heart rate, and the heart rate we calculate according to this formula. And then we analyze myocardial conduction depending on duration of P wave, PQ interval, and QRS complex. Then we estimate the position of electric axis and analyze the waves and intervals. So we will start from analyzing of P wave and determining different types of hypertrophies. Right and left atrium hypertrophy. For the first left atrium hypertrophy, it is also called P mitrale. So once again we have two waves in P wave. The first wave is depolarization of right atrium and the second depolarization of left atrium. And if we have hypertrophy of left atrium, it means that the second part of P wave will enlarge, and that is why enlargement of the left atrium amplifies this second part of P wave, and P wave will be bifid, will have two humps in the second standard lead, and in V1 P wave will have more pronounced negative part than normal. If we have right atrium hypertrophy, this P wave will be called P pulmonale. P pulmonale is a consequence of right atrium enlargement, and this is often a consequence of pulmonary valve stenosis or increased resistance in pulmonary circulation, like in COPD. And enlargement of right atrium causes an increased P wave amplitude in the second standard lead and in V1, and P wave will be high, more high than normal. So this is example of left atrium hypertrophy. In the second standard lead, P wave is prolonged and bifid, has two humps, and in V1 more prolonged negative part, more pronounced negative part of P wave. Right atrium hypertrophy, very high P wave in the second standard lead and in V1 also. Ventricle hypertrophies. Ventricle hypertrophies are determined by changes of ventricular complex, QRS complex. So for the first will be the change of position of the electric axis. In left ventricle hypertrophy will be a left axis deviation, in right ventricle hypertrophy right axis deviation. Then the amplitude of ventricle complex and its length will be increased, and the change of terminal part of the ventricular complex because of repolarization abnormalities. So we will detect ST segment depression and negative T. In left ventricle hypertrophy, amplitude of S wave is increased in V1, V2. Amplitude of R wave increased more than 20-25 millimeters in V4 and V6. In right ventricle hypertrophy, the changes in the S and R waves are the reverse. The high R wave, more than 7 millimeters, appears in V1 and V2, and deep S wave in V4, V6. So once again, these changes are formed by changes of the direction of main QRS vector in left and right ventricle hypertrophy. So we may compare two ACG, left ventricle and right ventricle hypertrophy. In left ventricle, the most pronounced air waves are in V5 and V6, In case of right ventricle hypertrophy, the most pronounced error will be in V1 and V2. ACG criteria or indexes for left ventricle hypertrophy. Pay attention on this slide. So the first criteria, Sokolov-Lyon criterion. This is the sum of the height of R, V5 or V6 and the depth of S wave in V1 and V2. It must be more than 35 millimeters, or the height of R wave in AVL more than 11 millimeters. Cornell voltage criteria is the sum of depth of S wave in V3 and R AVL. In men it is more than 28, in women 20. And the last, Cornell product criteria. The formula is presented on the screen. So, and you see that the most sensitive and specific is Cornell product criteria. But others, Sokolov-Lyon criteria and Cornell voltage criteria, are also used nowadays. So this is example of left ventricle hypertrophy. Example of right ventricle hypertrophy. Now we will continue about the ACG of coronary artery disease. So ACG may help us to know the stage and to know the type of coronary artery disease. So if we have stable coronary artery disease or stable angina pectoris, this type of coronary artery disease does not cause any ST and T changes at rest. And to reveal ischemic ST and T changes, the patient must undergo exercise stress ACG testing. If person with stable coronary artery disease displays QRS changes, for example pathological Q waves or something else, reduced air wave amplitude, it strongly suggests previous myocardial infarction. In case of an acute coronary syndrome, the ACG is used to classify the syndrome into ST elevation acute coronary syndrome and non-ST elevation acute coronary syndrome. This subdivision is fundamental because it affects the management and immediate treatment. ST elevation acute coronary syndrome with ST elevation on ACG are classified as ST elevation acute coronary syndrome, and all these patients will develop myocardial infarction, STEMI. Non-ST elevation acute coronary syndrome, these patients may develop myocardial infarction, non-STEMI, or may have unstable angina. So this slide also represents the classification of acute coronary syndrome into STEMI and non-STEMI. ECG during angina attack. So during angina attack, ischemia, acute ischemia of cardiomyocytes develops, and that is why these patients may have ST segment depression, like in this example. This is also example of non-STEMI, non-ST segment elevation myocardial infarction with ST segment depression and deep negative T waves. So remember that acute myocardial infarction is diagnosis based on cardiac troponins. So in order to differ non-STEMI and the attack of angina pectoris or unstable angina, we need the assessment of cardiac troponins. If cardiac troponins are elevated in patient with ST segment depression, the diagnosis will be non-STEMI. If troponin level is normal in patient with ST segment depression and negative T, it will be unstable angina. So once again, between attacks at rest, ACG may be normal in our patients, and that is why we may use the exercise ACG testing to provoke the ischemic changes. So now we will talk about ACG in case of ST segment elevation myocardial infarction, STEMI. In case of STEMI, we have three zones which may be detected by ACG. It is necrotic zone, ischemic zone, and the zone of ischemic myocardial injury. Switch off your microphones, please. So ischemia of myocardium is detected by T-wave. Subendocardial ischemia is detected by symmetrical acute high T-wave in overlying leads. Transmural or epicardial ischemia, symmetrical acute deep T-wave. The ST segment and T-wave changes during the first hours of the disease. The descending limb of the air wave transforms into the ST segment without reaching the isoelectric line. The ST segment rises above the isoelectric line to form a convexing arch and to coincide with the T wave. So a monophase curve is thus formed. These changes usually persist for 3-5 days of STEMI. Acute ischemia of myocardium causes a current of injury, of ischemic injury of myocardium. Subendocardial ischemia, the resultant ST vector directs toward the inner layer of the affected ventricle, and overlaying leads therefore will record ST depression. Transmural or epicardial ischemia, the ST vector is usually shifted to the direction of the outer epicardial layers, producing ST elevations. And sometimes in the early stages of ischemia, tall positive so-called hyperacute T waves. So ACG criteria of STEMI: new ST segment elevations in at least 2 anatomically contiguous leads. Man age more than 40 years, more than 2 millimeters in V2, V3, or more than 1 millimeter in all other leads. Man age less than 30 years, more than 2.5 millimeters. Women at any age more than 1.5 millimeters. But there are some other causes of ST segment elevations. These conditions may be left ventricle hypertrophy, left bundle branch block, acute pericarditis, pulmonary embolism, and some others. So we must analyze ACG changes and ST segment elevations with analyzing of clinical presentation of our patient. Not only record, ACG record, but also we must have in mind his clinical presentation. Myocardial necrosis is detected by pathological Q wave. So once again, pathological Q wave is characterized by prolonged width more than 0.03 and depth more than 25% of air wave. STEMI has stages: ischemic stage, pre-acute, acute, subacute, and scar stage. Ischemic stage of STEMI is detected by very high superacute T wave. Pre-acute phase, its duration up to 3 days. It is characterized by ST elevation. So in these days, ischemic injury is developed. Acute stage is necrosis. Its duration up to 3 weeks. It is characterized by appearance of pathological Q, ST elevation, and negative T. Subacute stage up to 3 months. It is the resorption of necrosis, and it is characterized by presence of pathological Q, air wave reduction, ST is on baseline, and negative T. And scar stage, the final stage, which lasts for the rest of the life, is characterized by presence of pathological Q, ST segment is on baseline, and T wave positive. Air wave is reduced. Air wave reduction. So this is the examples of STEMI, different types of STEMI. The first example: 60 years old male with retrosternal pain, and ACG shows ST segment elevations in inferior leads. It means the second stented lead, AVF, and third stented lead, with appearance of pathological Q wave, and very important idea, with depression of ST segment in AVL and the first stented lead. It is called reciprocal ST segment depression. Next example, the second example: 65 years old diabetic with 3 hours duration of chest pain, and ACG shows also ST segment elevation in the third AVL and second stented leads, and reciprocal depressions in the AVL first stented lead, and presence of pathological Q waves. Localization of myocardial infarction. You must remember this table, learn by heart this table, how to assess the localization of myocardial infarction according to the presence of changes of ACG. So this is example of myocardial infarction of the anterior wall of left ventricle, where ST segment elevation and pathological Q waves in the V2, V3, and V4, V5 chest leads, and reciprocal ST segment depression in the third and AVF. Myocardial infarction of the posterior wall of left ventricle. So ST segment elevation in the second, in the third, and AVF, and reciprocal ST segment depression in the first and AVL. lateral wall of left ventricle, ST segment elevation in V5, V6, in AVL and first standard leads. And there is no pathological cue, so we may make a conclusion that this is pre-acute stage of myocardial infarction, maybe 3 days to 1 to 3 days, so beginning of myocardial infarction. And this is also absence of Q wave, it is pre-acute stage of myocardial infarction, and in this case, if we have pathological Q wave, it means that it is acute stage of myocardial infarction, necrosis. This example of scar stage of myocardial infarction of the posterior and lateral wall of left ventricle, because we have only pathological Q. ST segment is on baseline. The P wave is slightly positive in the second standard lead, third standard lead, AVF, V5 and V6 chest leads.